Good evening, everyone. Thanks so much. It's so nice to see people this evening. Thank you. All right, well, I'll get us started. So welcome to today's Project Echo session, Ask the Experts, the role of immunotherapy in advancing the treatment of HCC and BTC. Tonight's session is the immunotherapy in the management of advanced BTC. I'm Sarah Bingham-McKillips. I'm with the Franz Foundation. I'm the staff facilitator for our session. And again, it's really great to see you all this evening to hear about the latest advances in HCC management. So before we start, although I see a few familiar faces, if you are still new to Project Echo, I'll take a brief moment to explain the premise behind our meeting format. Project Echo stands for the Extensions for Community Healthcare Outcomes. It's a global movement to share knowledge and expertise across distances, creating a learning loop where all the participants, including our experts and you, can learn from one another. These sessions are designed to be interactive. We really encourage you to make the most of our time this evening by asking any of your questions about your HCC or BTC cases. Your active participation really makes these sessions valuable. So again, thank you so much for being here tonight. I'm really looking forward to our informative session, and I will hand it over to Dr. Stein to get started.
Okay, thanks, Sarah. So welcome, everyone. Today, we're going to be talking about immunotherapy in the treatment of biliary cancer. And that's me and my disclosures. And here's information about the accreditation for the program. So for today, we are going to review the clinical profiles of immunotherapy for the treatment of advanced biliary tract cancers, formulate a plan that thinks about patient-reported outcomes and perspectives of the patients with advanced stage biliary cancer, and think about strategies for effective multidisciplinary communication and coordination, because it does take a team to manage these patients. And so we're going to talk a little bit about, the treatment approaches, the roles for immunotherapy, trial results, the importance of molecular testing, and, some of the trial data for targets that we have, and thinking about multidisciplinary tumor boards. And I have cases that we can go through, but if anyone has any cases of theirs that they'd like to discuss, feel free to put something in the chat, and we can certainly go over any questions or other cases. So to start off, we have a knowledge check. If you could use the QR code on the upper right and log on, and I'll read through the question. Which statement regarding the use of durvalumab or pembrolizumab with gemcitabine and cisplatin as systemic therapy for advanced biliary tract cancer is correct? Is it A, that current guidelines recommend durva plus cisgem and pembro plus cisgem as alternative primary regimens? B, current guidelines recommend durva plus cisgem and pembro plus cisgem as preferred primary regimens? C, current guidelines recommend durva with cisgem and pembro as cisgem as targeted therapies useful in certain circumstances? D, 3-year data are available only for durva plus cisgem? Or E, 3-year data are available only for pembro plus cisgem? All right, so let's talk about immunotherapy in biliary tract cancer. So to start off, when we think about cholangio, and we used to think of it as kind of one group, but now we really think of them as separate entities of intrahepatic cholangiocarcinoma, extrahepatic, which can include perihilar and distal, and then gallbladder cancer. And in terms of prevalence for the intra and extrahepatic groups, we see about 10 to 20% are intrahepatic, 20 to 30% are distal, and 50 to 60% are perihilar. The incidence of intrahepatic and extrahepatic cholangiocarcinoma, unfortunately, are rising. And so, even though it's not a very common cancer, I see a lot of these patients, so it always feels more common to me. but it is one of the few cancers where the incidence is projected to increase over the next few years. And if we look at the 5-year relative survival rate, we see the importance of having more early detection, more systemic therapy for the more advanced patients. So, if we think about the localized patients, some patients are cured, but those numbers are still pretty low. So we have the highest cure rate in gallbladder cancer, but even when they're found at a localized, setting, the 5-year survival is pretty poor for the intrahepatic and even worse for extrahepatic. And then for the distant disease, the 5-year survival rate is very uncommon. And so more than 70% of biliary tract cancer is diagnosed at an advanced stage. As you know, we have no screening for this disease, and initial symptoms are often vague. And by the time someone presents with biliary obstruction, they very well may have already had spread of disease and are no longer surgical candidates. And so, it makes it tough to treat. Also, the local and distant recurrence rates after surgery are significant. Most biliary tract cancers are not very sensitive to chemotherapy or quickly develop resistance. And you'll see that, the second line data is not very promising right now, but half the patients never even get second line therapy. And less than 25% of the patients are very fit for treatment, and the ongoing treatment and toxicity, and have a lot of symptom burden. For targeted therapy, and we could talk more about this, tumor biopsy samples, I don't know what your experience has been, but often we're getting fine needle aspirates or, just right cytology, and not good core biopsies. And sometimes there's not even enough tissue to make a diagnosis at the first endoscopy, and we have to repeat that. And even if there's enough tissue to make a pathologic diagnosis, there's not enough tissue to do genomic profiling. I've been getting a lot more liquid biopsies, and we'll talk about that a little later. And so, we have to think a lot about how do we make sure that we know what mutations these patients' tumors harbor. And then, for the checkpoint inhibitors, the use of monotherapy is really not effective. And we'll talk more about the combination data. So here are the NCCN guidelines, and you could see on the upper left.
Dr. Stein, I'm so sorry. I think there is a question.
Oh, sure. Yeah, sorry, I can't see the.
No, it's okay. Mohammed, do you have a question? All right. Well, I'll wait for him to type it in the chat. Sorry about that, Dr. Stein.
Oh, the QR code did not.
Oh, got it. Okay. Thank you so much.
Yeah, I don't know
on that.
Send the link again or something.
Yeah. Thank you.
Yeah. So for NCCN in the upper left, we have as category 1 under preferred regimens, cisgem. Oh, here it's in the chat now, the link for the code. We have cisgem with durvalumab and cisgem with pembrolizumab as preferred regimens. And then under other recommended regimens, as the NCCN panel kind of reviewed this, we left in combinations which are not always necessarily, used, but that we wanted to make sure if patients were being treated, with a higher bilirubin and weren't able to get these chemotherapy drugs, that they had alternatives. And then we have for second line treatment, the FOLFOX data, the FOLFIRI data. There's a few other things there. And then of course, we have targeted therapy for the patients that have those mutations. So here we have the TOPAZ and Keynote 966 child designs, Topaz on the left and Keynote on the right. And these were in some ways similar studies, so I'll highlight some of the similarities and differences. So in terms of the trial size, Topaz had almost 700 patients. The Keynote study had over 1,000 patients. These were all both international phase 3 randomized double-blind studies. And the populations were for untreated, unresectable, metastatic or recurrent biliary tract cancer, including intrahepatic, extrahepatic, and gallbladder cancer, patients with a good performance status. And initially, the patients either received cisgem with placebo or with the immunotherapy to a maximum of 8 cycles. So that's considered often like the standard, regimen. And then as maintenance, on the Topaz study, they continued to get durvalumab every 4 weeks or the placebo. And on the Keynote study, they were allowed to continue to get gemcitabine, and that was by investigator choice, how long to keep the gemcitabine on. Primary endpoints were overall survival for both studies, with multiple secondary endpoints, including progression-free survival, response rate, duration of response, safety. And so here are the key outcomes of the study. First, looking at median overall survival. And, I just wanted to point out, this is not a selected patient population, right? So we're not looking at any scoring for immunotherapy. This is for all comers. And so I think that often the medians don't really reflect the patient group that gets the most benefit from immunotherapy, which we have no way of kind of recognizing beforehand. So the median overall survivals for cisgem on these 2 studies, it was 11.5 on Topaz, 10.9 on Keynote, and then the combination therapy was 12.8 months and 12.7. And so I think that, if you're looking at this, it kind of appears underwhelming. The response rates were high on the Keynote study in both arms, 29%, and 19% with cisgem on the Topaz study, 27% with immunotherapy. The PFSs were also not that different, from 5.7 or 5.6 months to 7.2 and 6.5. So these are the key safety outcomes. So we looked at treatment-related adverse events leading to discontinuation, which were not that different across all 4 of these groups here. There were very few adverse events that led to death. There were some immune-related adverse events. Interestingly, the control arms had a significant number of immune-related adverse events. So I think it goes to show that some of these side effects are kind of hard to know what you're ascribing them to. But most commonly, patients had decreased neutrophil count, anemia, nausea. So, when we think about the common adverse events, I always try to educate patients about the itises, and that really they could happen anywhere in the body, but to think about, diarrhea, shortness of breath, any chest pain, eye pain, really significant fatigue, and just, skin toxicity that could feel like itching or rash, joint pain. And so I really try to empower the patients to call in real time and to never show up to the next treatment appointment telling me that they had a terrible week. And I try to empower whoever came to the appointment with them to also call if they think that something doesn't seem right. The toxicity management is really important. So we want to make sure that we're treating people as soon as possible, which means that they need to call us, and that we need the family, and their caregivers to call. And then, of course, we have to think about if we need to make treatment adjustments. And NCCN does have guidelines for the different immunotherapy related toxicities, which I think is helpful. And there's some, patient education information also. So here is the TOPAZ-1, the 3-year data. So there was a median follow-up of over 40 months. And fortunately, there was no real change in serious adverse events or treatment-related serious adverse events from what had been in earlier reports. And there were more patients, in the durva group that were alive at greater than 30 months after randomization. And so I think that's where we really start to see the differences in the two arms that to me seems more significant than the median numbers. So again, the median overall survival went from 11.3 to 12.9 months. But I think what's more impressive, if you look at the 36-month overall survival, it went from 7% to 14.6%. So there was more of a doubling. Now, granted, that's a small patient number, and I think we need more treatment options for these patients, but it does show that there is a group of patients that seems to be benefiting more from the immunotherapy. And here's the 3-year data from the Keynote 966 study. So this was a median follow-up of 36.6 months. And again, the safety did not seem to be significantly different for the group that was followed. And here we see kind of a smaller difference at the 36-month survival from 11% to 13%. So, going back, the numbers for the other study were higher in the control group and a little bit lower, and kind of more in the middle. And so both studies looked at patient-reported outcomes, which I think gives us a more accurate representation of how patients really feel than when we're just reporting it with our clinical trial staff, and interpreting what patients say, as opposed to them answering these questionnaires. But basically, the addition of durvalumab or pembrolizumab did not affect the patient's reports on how they felt compared to the chemotherapy alone. And the time to deterioration and global health score or quality of life scores were not different either. And then thinking about some other patient groups. So fortunately, we have some real world data as well, which then, usually reflects more of our general patient population. I would say that most of the patients that I have treated with biliary tract cancers were never going to be candidates for a clinical trial. And so it's always nice to see kind of real world data. So there were several retrospective studies looking at similar outcomes to TOPAZ-1. There was one large international study with over 600 patients that found a median OS of 15.1 months, a median PFS of 8.2, and a response rate of over 30%. And very few patients discontinued due to adverse events. And we saw, the things that we see most commonly with immunotherapy, like rash, pruritus, and hypothyroid. And then for the patients that were or were not in the inclusion criteria, so this was a small study that looked, only half the patients would have met the criteria, but it really seemed like overall they still did fine, and it didn't really impact the overall survival. I think I just jumped. Nope. Okay, sorry. And here is just a list of some ongoing phase 3 studies in biliary cancer looking at immunotherapy. So there's the, this one I think is a little hard to pronounce, the rilvegostomig plus chemotherapy, lenvatinib with PD-1 inhibitors, looking at FOLFOX with atezo and bev, durva with gem-based chemotherapy, a neoadjuvant study with durva tremi plus cisgem for intrahepatic cholangio, zanidatamab with standard of care for HER2-positive biliary tract cancer, camrelizumab and apatinib, and then also TDX1 in combination with other drugs for HER2 expressing biliary tract cancer. And so I think it's exciting that we're going to have more data in this patient group to really think about. And I wanted to talk about, the therapeutic targets that we have in biliary tract cancer. So the incidence of some of these are quite low. They are included in the guidelines because some of these drugs have agnostic approvals based on any disease type. And so they're in the guidelines, but really some of these we see pretty infrequently, like a RET gene fusion or an NTRK gene fusion. I have to say I haven't had a patient with either of those for all the patients that I've tested. Also, MSI tumors are fairly uncommon, but of course we should be screening because for the patient that you find, it's important to know. There's also only a few percent of patients that have a tumor mutation burden that is high. We do see occasionally BRAF V600E mutations, and then could think about giving targeted therapy. We do see in about 10% of patients with intrahepatic cholangio, but rare in the other subsites, FGFR2 fusions or rearrangements. Then we have data for IDH1 mutation targeted therapy, which is reported to be about 10 to 20% of intrahepatic cholangios. I have to say, I feel like in the population that I see, it seems like these numbers are a little bit lower than this reported data, but we still do see some. And then we see HER2 amplification in 5 to 20% of cholangios and about 15 to 30% of gallbladder cancer. So that's very important to check as well. And a low incidence of KRAS G12C mutations. And so we had put together a principle of molecular testing for biliary tract cancer. I think that was from earlier this year to kind of think about, which areas we should be testing. I mean, realistically, I think most patients are being tested by a large panel. And so we're not necessarily picking and choosing which one of these to check, but, like the gallbladder patients are still, if you're ordering a liquid biopsy or full panel from their biopsy, you're still going to be getting the couple of mutations there that are lower incidence in gallbladder. And so here's the NCCN guidelines for thinking about drugs for these targets. So we do have the drugs for NTRK fusion positive tumors, although the chance of, I think, having one of these patients is quite low. For the MSI high patients, we have pembrolizumab. For the tumor mutation high tumors, we have the combination of IPI and Nivo. And then there are the RET gene fusion targeted therapy, which is also unlikely to be used. And so then we have this down on the bottom for subsequent lines. And so for the BRAF V600E mutation tumors, we have the combination of dabrafenib and trametinib, sorry. And for the FGFR2 fusions or rearrangements, we have futibatinib and pemigatinib. And for the IDH1 mutations, ivositinib. And then for HER2 positive tumors, we have the options of deruxtecan, trastuzumab and pertuzumab, and tucatinib and trastuzumab. And then there's adagrasib for the G12C mutation positive tumors and the RET gene fusion targeted therapy as well. And we do know that if we have matched targeted therapies for these patients, we can improve their survival. And so this was a study where they looked at these tiers of patients who had alterations that received targeted therapy, or patients, so that's in the blue top line, or patients in green that received second line treatment, but it wasn't targeted. And then there's the group where there was no alteration found. And so we know that we still have a lot of work to do, but, recognizing that for the patients who do have these mutations, it's important to make sure that we're offering them the targeted therapies. So it's now standard that patients unless they have a real contraindication to immunotherapy, that they receive immunotherapy in addition to their chemo. Molecular profiling is really important. I test everyone at the time of their diagnosis. So even when they're just starting first line therapy, so that we kind of have a map ahead of us of what we might use next. And then, to really think about the barriers to care and support these patients. They often carry a high symptom burden and really need a lot of resources sometimes to come to appointments, support their nutritional needs, their emotional, support needs, etc. All right, so we'll do a knowledge recheck, and hopefully now either the QR code is working or Sarah put a link in the chat if someone wasn't able to open that. So again, which statement regarding the use of Durva or Pembro plus Cisgem is correct? So is it A, that current guidelines recommend both regimens as alternative primary regimens, or B, that they are both preferred primary regimens, C, that their targeted therapies useful only in certain circumstances, D, that there's 3-year data only available for the Durva plus Cisgem study, or E, that there's 3-year data available only for Pembro plus Cisgem. So I'll give you a second to do that. Okay. And so I just wanted to talk a little bit about a case and how we really think about, treating these patients. So this is Ms. Golden, who presented with malaise, tea-colored urine, and light-colored stools. She had imaging that showed a 3-centimeter obstructive mass in the hepatic hilum. She did undergo resection and received capecitabine as adjuvant therapy. Now, we did not discuss here today adjuvant therapy, and I think it is another unmet need. There was a study called the BILCAP study that looked at adjuvant capecitabine versus placebo, and it was actually statistically a negative study, but trended toward positive. And we could dissect the data to really think about each subgroup of patients. But while we often offer capecitabine for 8 cycles as adjuvant therapy, it's not really strong data that seems to be making a large survival difference in this patient population. So then this patient continued to have surveillance imaging for over 3 years that showed no evidence of disease recurrence. But then she started to develop symptoms of abdominal bloating, and she had a repeat CT that showed now the development of ascites with peritoneal nodularity, and a biopsy was obtained that showed metastatic cholangiocarcinoma. And at that point, molecular profiling was ordered. And so, this is not uncommon for patients to develop ascites with this disease later. We often see this, unfortunately, also at time of, sometimes this is part of the presentation. And then managing the ascites is a tough part of the management. So now thinking about this patient with recurrence, what would preclude use of a preferred systemic regimen? Do we think that this patient is a good, candidate for treatment? So certainly we think about performance status, their overall health, their medical issues. Do they have any contraindications for immunotherapy? I think, often patients are presenting with a lower performance status, and it is important, I think, to try to offer them therapy. Sometimes they may not be candidates for the triplet regimen, but they could get dose-reduced chemotherapy or gemcitabine alone with immunotherapy. But I really, especially because we don't have a a way to predict who really gets that benefit of immunotherapy, and they really do usually tolerate it well, I really try to make it part of everyone's regimen. And I don't know if anyone has any opinions or, thoughts about what preferred regimen to use, but I think, as you see the data from the Topaz and Keynote study, the results are pretty similar, I think, for the addition of immunotherapy to chemo. And in terms of multidisciplinary care, we actually have a GI tumor board and a liver tumor board. Usually the cholangio patients are presented more at the GI tumor board, but occasionally at the liver tumor board, depending on how they kind of came into the institution and who saw them first. But I think having a good discussion, with radiology, pathology, our surgeons is really important. And sometimes, of course, for some of the patients have to put in stents at the beginning of their treatment, and we rely on our endoscopy team a lot. So what is the earliest stage at which we give systemic therapy? That's a good question. So I think that even the early stages of cholangio are at high risk. And usually, though, for patients who are really surgical candidates at the beginning, they go to surgery. That being said, there are some studies now looking at either a neoadjuvant approach for those patients who seem resectable, or there's a cooperative group study that is looking at patients that they've kind of identified as high risk for recurrence and thinking about giving them some treatment prior to their surgery to see, given our lack of kind of very robust adjuvant data, if that would be, useful. And then, of course, we think a lot about our patient support systems. I think it's very hard when patients don't have family or friend support or come to appointments by themselves. And so it's good to know that someone's kind of checking on them at home, either someone that lives with them or someone coming by frequently. We try to set up visiting nurse care for patients that seem like they would benefit from it. Trying to help with treatment access and, sometimes assisting with rides to our appointments, to different procedures, and really kind of thinking about barriers to care. We have a great social work team. We have nutritionists. I have a great palliative care team as well. And I often refer these patients very early to palliative care because I think they often do have a symptom burden. And between the symptom burden, kind of thinking about having a non-curative diagnosis, and for the emotional support, I think it's been very helpful to get them involved early in this patient group. So this patient was recommended for palliative systemic therapy with cisplatin, gemcitabine, and durvalumab. After discussion of the risks, benefits, barriers, impact on quality of life, she decided to go ahead with the therapy. And after 2 months of treatment on re-imaging, she had decreased nodularity of the peritoneum, and it seemed like the bloating and distension was improved, which is great. And then, we kind of think about, as someone's on treatment, how much treatment to give. Often, depending on someone's age, they may or may not really tolerate full doses of 8 cycles of chemotherapy on the day 1, day 8 schedule. But usually they tolerate the immunotherapy well, and they usually do need chemotherapy dose reductions, especially for their counts. And then we think about de-escalating to, maintenance immunotherapy after 8 cycles. This patient would not become a surgical candidate, but sometimes we have patients that have more like a locally advanced picture that seem like they're better resection candidates kind of after treatment. So we would always reconsider that. And then we really have to think about, their molecular profiling. And so, I like to get that early because if they do have a BRAF mutation, HER2 amplification, FGFR2 amplification or rearrangement, IDH, then you really know what your next line therapy would be. I would say if they don't have an alteration and someone could be a clinical trial candidate, I try to get them in to see phase 1 even before they progress sometimes, just so they can kind of think about possible studies and kind of understand the process better. And I would, if they were a trial candidate, I would really try to prioritize a trial in the second line over just standard FOLFOX or FOLFIRI, because the progression-free survival and survival data for those two studies is, I think, very limited and would be underwhelming data to most patients and their families. So, as opposed to some other diseases, I think second line is really appropriate for phase 1 studies. And, with that, I know we're a little bit early, but I'm happy to kind of talk about any other data in this patient group. But I really thank everybody for joining this evening and listening about advanced biliary cancer.